So this is our welcome slide. This is myself. As before, I am Dr. Osman Ghani, working as Associate Professor in the Department of Medicine, Dhaka Central International Medical College. In addition, I am a member of Royal College of General Practitioners, UK. So this is our actually logo for you. You have seen it before. And this is our SAM alert. Really, it is a very restricted material, though we are very generous to disseminate you in a proper way, in proper modification and updating. So for the first slide is very historic slide, really. You see that the Röntgen, how he developed the X-ray, is preserved in the museum, and he was awarded Nobel Prize for this. So I think everybody could be delighted looking at this picture. I think everybody can see, right? Of course. So we're entering now our main topic of chest X-ray. First of all, please look at the X-ray. I mentioned that this is normal X-ray. Even then, you can have a look, few seconds. Technical qualities of a chest X-ray, especially these are the film is inspiratory film or not. Traditionally, the chest X-ray be done in standing position and in a PA view, and patient breath hold at the height of inspiration. So if it is not maintained, these technical things are not maintained, the X-ray evaluation might be wrong. Interpretation might be technically wrong. So some few things over there. So look at two X-ray here in the right side. That means right side of my screen is the inspiratory film and the expiratory film. You can find that the cardiac shadow is enlarged. Then this inspiratory film one. So this one expiratory, so there is elevation of the diaphragm, cardiac shadow seems to be enlarged. So simple technical thing, nothing else. If we ignore it, the report may come as cardiomegaly. Okay, and there is some increased vascularity due to expiration, increased vascularity, especially in the lower part of the lung. You see, there may be a little haziness is more. So it may give some pathologic idea in the person who is looking at the X-ray. So now come to the point of penetration. Spine should be barely perceptual. That means it would be much difficult. It is not impossible to see, but with difficulties, the spine can be seen through the heart. Just look at two X-ray. So this is right X-ray, this is left X-ray. That means in the screen, this is right, I mentioned. The cursor is, I am moving over. This is left. You find that their vertebrae are visible with difficulties, but here totally not visible. It means that the X-ray is not penetrated. That means ideally what amount of X-ray should go through these, it is not gone. So this is whiter more, vertebrae are not visible. So penetration is less. So what is the difference of the outcome? You see that there are some bihilar shadows are there, increased vascularity, bronchovascular markings are more visible. So again, this is due to technical error. The X-rays rays are not penetrating much enough, which is a standard. So this is one wrong information reason here. Again, the technical problem is penetration. Is the difference due to congestive heart failure or penetration? Can you opine here? Anybody?
Penetration.
Yes, this is penetration. Just before I have shown one X-ray like this. So this is less penetrant X-ray. Less penetrant X-ray. And now comes the point of rotation. You know, right and left rotation, obvious in the tracheal position. So the spine vertebral spine, you see here, it should be equidistant from the clavicular end. If it is not equidistant, the mediastinal shadow, heart shadow will be bigger. So just compare here. I'm not telling that this in the first X-ray, the rotation is there or not. Maybe there is some rotation also, but there is some obvious pathological problem. If we compare these two problems, even in the left side X-ray, the second X-ray, the trachea is more shifted to the right, but it is of the same patient. If it is the same patient like this, so you see that trachea is a little to the right, but here much right from the spine. It is due to only for the fault in the rotation, only fault in the rotation. So tracheal shifting, you know, even junior doctors also, and even the clinical students know that the significance of shifting of the trachea in the lung disease diagnosis. You see another X-ray, the distorted mediastinum due to tortuous aorta and rotation. Okay, aorta is tortuous, maybe in the elderly patient, but or aorta is dilated. But if trachea is not central, very difficult to say that this aorta is dilated or tortuous. This is a technical point. Now the point is orientation, epi or PA view or lateral view. It is usually mentioned in the film. So sometimes relying on the mark on the X-ray may confuse us, because the person who was giving the mark, there are some radio technicians, they might be in hurry also, they might do some mistake, and it is very practical. We have seen that right side actually it is not right. For that, we have to understand this is right or left. Usually some soft organ, solid organ rather to say, the liver can guide us, right? The funding gas in the left side, liver in the right side. This is a common practice of us, that this is right or left, though there may be rarely some problem, is it? And this is PA or epivio. This is also important. You see, this is epi means X-ray tube is placed behind and ray gone from anterior to the posterior chest, and it can give an idea of cardiomegaly. So X-ray should be done from the back. X-ray should be in the inspiratory film. It should be right, left orientation should be there well, and this PA and epi also to be correct in our eyes before going to any identification of the abnormality in the chest X-ray. Again, you see the erect and the supine X-ray. This is again part of orientation. We like to say that this is erect and this is supine in the, I think in the second X-ray. So again, there is elevated dome of the diaphragm, and it seems to give an idea of cardiomegaly. The heart is magnified. So again, this is the difference of the, and it is mentioned. It's, you see, this is not mentioned. If it is not mentioned, very difficult. The doctor who is advising this, he knows, you know, in the meantime, junior doctors, those who are working in the world, that any emergency patient cannot stand well. We cannot take any erect posture X-ray. So let's get a mobile X-ray machine, portable X-ray. They come and make X-ray sometime, and usually it is epi view, patient usually in the supine position on the bed. In these X-rays, if there is cardiomegaly, we have to be cautious to give an opinion pathologically there is heart is enlarged or not. Don't think that the patient should not have enlarged heart, but we have to be very cautious to comment on. If clinical symptom sign is not favoring that there is cardiomegaly, it might be due to only technical error. Okay. So you see that this is supine epi view, you see, and this is erect posture. In the erect posture, we are much habituated to look at this X-ray. You see that this is pleural effusion. This erect posture, you see, lower dense opacity with curvilinear upper margin. Everybody of you know will tell that this is right-sided pleural effusion. But if you look at the upper X-ray, it is not, it's much different from this X-ray. So in the undergraduate classes or even in the junior doctors also may tell that there is some opacity in the right mid or lower zone of the right chest. But you see, for the lying patient, the water is spread over there and this dense opacity is gone. If you don't know that this is supine X-ray, then you may comment wrongly, maybe something other diseases, not pleural effusion. So this is also very fantastic extra difference I like to show you now. Angulation is, there is some kyphosis and scoliosis of the vertebra. That means the spine is abnormally angulated. It can give wrong ideation of the lung and heart shadow in the X-ray. And this is the angulation. You see, this is the normal X-ray. You see, there is some problem of the spine, and the epi and lordotic, it is called lordotic view, like a lord standing. You see that clavicle is stand in a standard position in the upper part. Apex is not much visible, but here apex is more visible. This is the clavicle. So sometime for benefit of the information also, we have to advise epi view, epi lordotic view. If I am in front of you lively, I can show you how to stand, just like English lord, you know, just placing the upper part of the body back and placing the lower trunk projecting front. This is the lordotic position, and a clavicle is as such. Sometime if any apical shadow is confusing to us, suppose tuberculosis lesion is there, we are not confident that the apical part of the X-ray film is normal or not. At that time, we can advise lordotic view. That means apical lordotic view or apical view. In that case, you see how bigger areas are visible in the apical area of this lung. So sometimes it is beneficial to be done. But if you don't know that there is clavicle is here, if you think that this is a standard chest X-ray, it may give some wrong idea also. Okay, now in summary, what will be the example of good X-ray? The X-ray is done after end of inspiration, and penetration is perfect. The vertebrae are visible, hardly visible. This is normal penetration, and there is no rotation, right? Because the spinous process in the middle between the distance of clavicular ends, and orientation, this is right, and you see this is left, heart is in the left side, liver in the right side, and there is no angulation of the vertebra. So these are technical qualities. This is a perfect X-ray of chest in sense of qualities, technical qualities.